Welcome to this video on basic ECG analysis and interpretation. We will cover a systematic approach to reading the heart's electrical language. What exactly is an ECG? It records the heart's electrical activity over time, encompassing depolarization, which is electrical activation leading to contraction, and repolarization, which is electrical recovery leading to relaxation. We use it to assess heart rate and rhythm, conduction abnormalities, ischemia or infarction, and electrolyte imbalance. Here we see an example of a normal 12-lead ECG demonstrating a normal sinus rhythm and intervals. This serves as our baseline for comparison when analyzing abnormal readings. Lead reversal, such as swapping the left and right arm leads, produces specific artifacts. Notice how lead I is inverted and leads AVR and AVL are swapped. Recognizing this pattern is key to avoiding misdiagnosis. Poor electrode contact causes artifacts like baseline wandering, making the reading appear noisy or fuzzy. This inadequate skin contact obscures clear wave analysis and is a common technical issue. ECG paper standardization ensures consistency across different machines. The standard settings are 25 mm per second speed and 10 mm equals 1 millivolt calibration. The grid system uses small squares of 0.04 seconds and large squares of 0.20 seconds for time measurements. Overcalibration, defined as greater than 10 mm per 1 millivolt, exaggerates wave amplitudes. This can lead to a false diagnosis of conditions like ventricular hypertrophy because the R waves and S waves appear too large. Conversely, undercalibration, less than 10 mm per 1 millivolt, diminishes wave amplitudes. This effect can mask significant ECG findings, such as pathological Q waves or signs of ventricular hypertrophy. Electrical interference, often called AC noise, creates a thick or fuzzy baseline due to rhythmic oscillations. This noise can make clear wave analysis difficult and sometimes mimic muscular activity or tremor. The heart's electrical system, or wiring diagram, includes pacemaker cells like the SA and AV nodes that initiate the rhythm. The conduction pathway involves the bundle of His, bundle branches, and Purkinje fibers to trigger ventricular contraction. ECG leads are categorized into standard leads and chest leads. Standard leads provide views of the heart's electrical activity in the frontal plane, while chest leads capture the horizontal plane. This table summarizes the typical ECG leads and findings associated with different anatomic locations of an acute myocardial infarction. For example, an anterior MI involves leads V1 through V4 and usually shows ST elevation of 2 mm or more. The ECG waveform consists of several components: the P wave for atrial depolarization, the PR interval, the QRS complex for ventricular depolarization, the ST segment, and the T wave for ventricular repolarization. Normal duration and shape are crucial for interpretation. Cardiac axis determination relies on the QRS relationship in lead I and AVF. A normal axis means both leads are positive. Deviations, such as left axis deviation or right axis deviation, occur when one or both leads are negative. Finally, we consider the causes of cardiac axis deviations. Right axis deviation can be due to right ventricular hypertrophy or lateral STEMI. Left axis deviation is often associated with left ventricular hypertrophy, left bundle branch block, or inferior MI. The systematic ECG analysis follows a 5-step process to ensure no crucial detail is missed. This includes checking patient details, assessing rate and rhythm, analyzing waves, measuring intervals, and examining segments. Step 1 involves determining the heart rate, normally 60 to 100 beats per minute. 3 primary rules are used: the 300 rule using large squares, the 1500 rule using small squares, and the 10-second rule counting QRS complexes over a 10-second strip. Step 2 is rhythm analysis, focusing on consistency, PQRS relationship, and conduction. Normal sinus rhythm requires a present P wave, a P wave before every QRS, and a regular rhythm. Atrial fibrillation, or AFib, is characterized by an, quote, irregularly irregular rhythm. Key diagnostic criteria include absent P waves, the presence of fibrillatory waves, irregular RR intervals, and a variable ventricular rate. Step 3 involves P-wave analysis, which represents atrial depolarization. This analysis helps detect atrial enlargement. The first half of the P-wave reflects right atrial depolarization, and the second half reflects left atrial depolarization. Right atrial enlargement, or P pulmonale, is characterized by tall, peaked P waves, typically greater than 2.5 mm in height in lead 2, and often seen in leads 2, 3, and AVF. Common causes include chronic lung disease. Left atrial enlargement, or P mitral, shows prolonged and notched P waves, with a duration over 120 milliseconds in lead 2, giving an M shape. A biphasic P wave in lead V1 is also common. It is often caused by mitral valve disease. Here is an ECG strip illustrating both P. pulmonale and P. mitrale features. Step 4 focuses on PR interval analysis. A short PR interval, less than 120 milliseconds, is a key finding in pre-excitation syndromes like Wolff-Parkinson-White and Lown-Gannon-Levine, or AV nodal rhythm. Wolff-Parkinson-White, or WPW syndrome, shows pre-excitation of the ventricles. ECG features include a short PR interval, a broad QRS complex, and the pathognomonic delta wave, which is a slurred upstroke to the QRS. Lown-Gannon-Levine, or LGL syndrome, involves pre-excitation via an intranodal bypass. The ECG is characterized by a very short PR interval, but a normal QRS complex, notably lacking the delta waves found in WPW. A V-nodal or junctional rhythm is a narrow complex rhythm originating from the AV node. Key features include abnormal P waves, which may be absent or inverted, and a narrow QRS complex, usually less than 100 milliseconds. This rhythm is also characterized by absent P waves and a narrow, regular QRS complex, acting as a rescue mechanism when the SA node fails. Step 5 is QRS complex analysis. The normal QRS width is 70 to 100 milliseconds. Narrow complexes indicate a supraventricular origin, while broad complexes, over 100 milliseconds, may be ventricular or due to conduction delays like bundle branch block. Left bundle branch block, or LBBB, is identified using the William mnemonic, a W shape in V1 and an M shape in V6. LBBB also features a wide QRS complex, greater than 120 milliseconds, and discordant ST segments and T waves. Right bundle branch block, or RBBB, is identified by the Marrow mnemonic, M shape in V1 and W shape in V6. It features a wide QRS complex, greater than 120 milliseconds, and secondary repolarization abnormalities. Ventricular premature beats, or VPBs, are abnormal, broad, and occur earlier than expected. They are typically followed by a full compensatory pause before the next normal beat resumes. Ventricular bigeminy is a specific rhythm pattern where a ventricular premature beat follows every single normal beat, resulting in a characteristic 1-to-1 ratio. Complete heart block, or third-degree AV block, results in no conduction of P waves to the ventricles. The ventricles are then depolarized by a slower ventricular escape rhythm, leading to dissociation between P waves and QRS complexes. Ventricular tachycardia is a rapid, regular rhythm originating from the ventricles. It is characterized by wide QRS complexes, typically at a rate over 100 beats per minute, as seen in both the 12-lead and rhythm strip. Polymorphic ventricular tachycardia, or torsade de Pointes, shows wide QRS complexes with multiple morphologies and changing RR intervals. It is often associated with a prolonged QT interval and reversible causes like electrolyte imbalances. This ECG shows polymorphic VT with a subsequent intervention by an implantable cardioverter defibrillator, or ICD, represented by the large arrowed deflection in the rhythm strip. Ventricular fibrillation, or VFib, is a chaotic, disorganized rhythm that results in no effective cardiac output. It requires immediate electrical cardioversion, as it is a fatal rhythm and will lead to asystole. An acute pulmonary embolism, or PE, can present with several ECG characteristics, including the S1Q3T3 pattern, sinus tachycardia, T-wave inversion in V1-V3, and often a right bundle branch block. Step 6 in the analysis is the ST segment. This segment represents the interval between ventricular depolarization and repolarization. Abnormality here is most commonly due to myocardial ischemia or infarction. Causes of ST segment elevation include life-threatening conditions like acute myocardial infarction and other conditions like pericarditis, benign early repolarization, and Takotsubo cardiomyopathy. The morphology of the elevated ST segment in an acute STEMI can vary. It may appear concave, convex, or obliquely straight, and identifying these shapes can aid in diagnosis. Various other conditions also produce ST segment elevation, each with unique morphology, such as in pericarditis, benign early repolarization, left bundle branch block, LV aneurysm, and Brugada syndrome. Acute ST elevation myocardial infarction, or STEMI, is regionally classified by the leads involved. The injury localization, such as septal, anterior, or inferior, is determined by the pattern of ST elevation across different leads. Coronary vasospasm, or Prinzmetal's angina, mimics STEMI with transient localized ST elevation and reciprocal depression during chest pain episodes. Crucially, these changes are reversible with treatment and are not typically associated with myocardial necrosis.